I guess, in the big picture, when we've been working on the Partnership for Coverage, which is, for those of you who don't know, the governor's initiative with the Department of Health and Department of Insurance to try and come up with alternatives to expand coverage. We've been working with the Urban Institute to model different possible reforms that we may be proposing. And everything Kathy outlined are some of the things that we've been considering, and certainly we've heard in a lot of the public hearings and the individual stakeholder meetings that we've been having with a broad variety of groups. And really a lot of it deals with risk, and how do you deal with risk. There are those, many in the insurance community, though certainly not everybody, who want to kind of break up risk more and do more individualized underwriting, et cetera. Of course, New York has community rating, open enrollment, and we do certainly have a pretty serious adverse selection problem with our individual direct pay market. And there's a lot of different reasons for that if we want, we can go into. But in the big picture, I'd say the other side is people who are saying, no, we got to go in the opposite direction and try and get bigger pools, standardized products, more covered benefits, and get everybody into the pool. And the modeling results are going to be coming out soon, but I would say based on what we've seen so far, nothing's probably going to shock anybody in terms of some of the take-home messages about what you get by pooling versus not pooling. And so just a couple of quick comments about what Kathy was going over. Number one, just to mention real quick, New York does have a bad debt and charity care pool. It's not the same thing as what you guys have, but that is, and I don't want to get into minutiae, but that is one of the potential sources of funding that everybody's been looking at here as part of how do you fund some of these expansions we've been talking about. We mentioned adverse selection, and when Kathy did a great job of talking about how in most states health insurers try to deal with avoiding high-risk people, medical underwriting, not issuing people policies, which in New York isn't really an issue, but certainly pre-existing exclusions can be an issue. We've tried to deal with that with the Benesowitz decision, which somebody wants asked me about, and I'll go into it. But certainly there's a certain amount of benefit differential where we're seeing a big broad picture shift in the market towards more high deductible plans with less generous benefits and more, well, some people call them cheaper plans, and employers are asking for those. On the other hand, there's a lot of employers who feel bad about that and feel bad that they're offering worse and worse benefits, and certainly there's a lot of concern about a race to the bottom that we're engaging in here, big picture. Geez, I got a lot more comments, but I'll just stop there. I mean, it was all really good stuff, and so in the big picture, for those of you who don't know, there's certainly some things that we've done, and Jay will probably touch on those to try and expand coverage already. The obvious ones that most people know about: expanding Child Health Plus to 400%, Family Health Plus to 200%. A lot of the Medicaid reimbursement reforms that we fought really hard to get to try and rationalize the system, try to reduce some of the administrative barriers to enrollment. We are looking towards a number of initiatives. We have a few out this year, but a number that we're looking to set up next year, and that we're hopefully that's going to be complementary with a lot of the stuff that's going on the federal level. I'd say, in general, we're looking towards bigger pools and trying to spread risk more, but absolutely, 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 I think there's a very keen recognition that if we're gonna cover more people, we got to deal with underlying costs. And there's a number of ways that we're talking about doing that, and I feel like if I could could talk for half an hour just about that, but certainly the Medical Homes Initiative in the North Country, and dealing with reimbursement reforms. We've been talking about efforts at medical guidelines, dealing with excessive emergency room charges by out-of-network doctors, a lot of things around the edges. I would agree there's no one magic bullet, but we need to be doing more.
But what I particularly liked was the categories. How do you deal with high-risk people? Deal with high-risk people, deal with some people, or try to get at it through dealing with all people. And I was thinking about New York as you were speaking, and we're somewhere between dealing with the high-risk people and dealing with some people, because we've started out by trying to reach our people or give access in the individual health insurance market, which I think is critical, by introducing community rating in 1992, and that was a great start. It gave access to health insurance without regard to people's condition, both in the individual and small group market. But then immediately we saw different access issues in that there was coverage available to people, depending on what their needs were, and a lot of carriers would tailor the coverage to the type of risk they wanted to obtain, similar to what you suggested in your presentation. So in 1996, we standardized our individual market in New York State, and we have basically one product, although it can be purchased either with an out-of-network option or purchased so that you only can use your HMO providers in order to obtain the care. One product, everybody's in it, therefore if you're healthy, you're sick, you're young, you're old, you should be purchasing it. We tried to put all the risk in one place, and years from now we're starting to see some of the problems that flow from that. It's a fairly comprehensive product. People purchased it if they had a need. You consider whether you need it before you buy it. All of those things. So we moved towards trying to introduce some money. In order to support it. We did that with a stop-loss mechanism, which I think fell into the high-risk category to try and introduce some money in order to support it, level out the premiums. And then we also, through our market stabilization mechanisms, we basically have a mechanism that extends to both the individual markets and our small group market that basically collects money, and it basically takes from the carriers that have better, and the products that have better than typical risk, and gives to the carriers and to the health insurance products that have worse than typical risk. That shifts a good deal of money towards that market. But is it enough? So it's interesting to me. If you try to approach this through attacking the high-risk population itself, logically it makes some sense. 2% of the population driving, I don't remember, maybe I should go with the 1% since I remember it, 1% driving 30% of cost. If you do take that risk out of the pool, you obviously can get something done, but there needs to be a strong commitment to funding. If you do take the some people approach and try to address it through community rating, aggregating, voluntary type methods of reaching people, you need a certain level of funding, and it needs to be enough. You spread the risk some, but you need the funding there to help support it, because this is the risk that's driving the problem. So as we look to making this more affordable, making coverage more accessible to people, it seems very, very much key that we take a hard look at what states like Massachusetts have done to get everybody in, because if everybody's in, the costs are spread as broadly as possible. We take a lot of care with the risk selection in the products that are designed to make sure that the core risk is not concentrated all in one place. We have a lot of experience with that so far. I think we've built a lot there that we can build off of further. But it's exciting as we look at possibilities and look at the federal proposals that are expanding coverage. Both giving options to reach the lower income people through increased subsidies, the possibility of subsidies for private coverage. We need to look at private reforms, because it seems clear that if you just do it through the through the public mechanisms that won't achieve affordability, you'll achieve it at a very high cost to government. And what mechanisms we need to do to make sure people share in the responsibility.
I'm going to speak a little bit more about the Medicaid program and what we're doing and how I think it fits into some of this. I think the first thing that I would say is that there is plenty of money. We have all the money we need for universal coverage right now. We don't need any more. In fact, we can save a great deal of money right away. And I would just say that, in New York, we have almost 4 million New Yorkers covered under Medicaid or Family Health Plus. We had 137,000 new enrollees to Medicaid last month alone. We cover 45% of the births in the state. So we believe that by creating standards of care, that by monitoring care, by conducting quality assurance, we will influence the care of all New Yorkers, certainly the entire new generation of New Yorkers. And to that end, we have made significant and fundamental changes to both reimbursement and clinical studies in the Medicaid program over the past 2 years. We've revised inpatient and outpatient payments. Our new inpatient payment system will save this year perhaps $250 million. Our new outpatient system, the ambulatory products grouping system, increases fees considerably, and we're taking all of the inpatient savings and moving them to the outpatient system. And really, through a mechanism of bundling high-cost diagnostics, we avoid in the fee-for-service system some of the abuses of the love of new technology or risk aversion that many providers have. We paid last year starting an additional rate for evening and weekend hours in the Medicaid program. We pay an additional rate now for self-management teaching. We pay an additional rate as of this year for substance abuse and mental health screening by physicians. We doubled that fee for ER doctors. We have implemented in the program a predictive modeling algorithm which was developed here in New York, but was just recently adopted by the NHS in the UK, in which we are looking at patients for near-term adverse health events. And we believe that we have a $40 million demo this year to look at that. On the agenda moving forward is, of course, expansion, because we believe that healthcare will affect healthcare costs. As people receive care, that we can eventually gain some control over the evolution of healthcare costs. But there's many other areas. This year, we've seen things from the Senate talking about bundling of payment. We've done our own assessment in the Medicaid program and saw that there were, for preventable admissions in the past, within 30 days of discharge, we spent $800 million last year. $800 million would be able to buy us up to 250% of federal poverty for everyone to be in the Medicaid program in New York State in the upcoming year. So if we were able to avoid those readmissions within 30 days, we would have been able to really cover a very significant part of the uninsured in New York State. In order to get there, we're going to have to be innovative. We're not going to be able to take money away from hospitals. But we also can't make insurers toothless. One of the big problems, I think, in being able to achieve coverage is that we all want what we want when we want it. And we have to be able to accept that we need that utilization management isn't a horrible thing, that formularies aren't a bad thing, and that we need to be able to follow some rules. And I would say that this is really a middle class problem. And I think as we move forward, we're all going to have to join together. Because frankly, the Medicaid population, while we're covering the aged, blind, and disabled, we spent $2,140 last year in 2008 for every child in the Medicaid program, on average. For every adult in the Medicaid program who wasn't aged, blind, or disabled, we spent $3,554. Far better, far more effective than what we would see in the commercial marketplace. Now, we haven't leveled the taxes we have on Medicaid that we have on commercial insurers. But that can only be driven through really insurance mechanisms. And I think that we're going to have to all come together on this as we move forward. Thank you.
Hospital Association of New York State, now the Healthcare Association. Heard a lot of things that were both good and bad. From our point of view, first of all, cuts are not reform. Secondly, using the indigent care pool that basically reimburses 50 cents on the dollar for our care for the uninsured. We would like to have those people covered before you take away the funding, just to make sure that it's enough to cover the amount of costs that we do incur for those people that opt out of the program. We definitely want to work hand in hand. We believe that universal coverage is a key concept. We do believe that healthcare reform is necessary. One of the places where I think, personally, I would like to see reform is having, particularly in the Medicaid managed care arena, those plans held responsible for utilization that's not really proper. We should not have people entering the system through the ER. The correct place is through the clinic and through private physicians. Very few private physicians do take Medicaid, unfortunately. We are the provider of choice and basically the only provider in many communities for those services for those high-need patients. So I think that there has to be a joint solution from the provider community. I think that spending money on an extra layer of insurance needs to be proven, whereas, for example, dollar for dollar, all the money is going to the providers from the indigent care pool. There's not that administrative costs that would be heaped on top of providing that care. So I think that needs to be worked on somewhat. A little bit nervous that the indigent care pool is $1 billion resource of funds. Currently, we've shifted another $300 million from GME funding, graduate medical education funding, into that pool in order to alleviate some state shortfalls by getting a federal match for those funds. We want to make sure that the understanding that providing physicians education is extremely important and is one of the leading industries in New York State that we're very proud of as a healthcare community. The other issue, so I guess my first question is, how do we hold the Medicaid managed care companies responsible for making sure that primary care, I think, is the key to it, that they provide primary care, that they facilitate and actually ensure that there's correct utilization of services, which I think you might agree that has not happened in the past. Mandatory Medicaid managed care has been in effect since '95, I believe. So I think that we have kind of a long way to go, and I think that talking about the bully pulpit, the health department does have the bully pulpit as far as the Medicaid managed care, and hopefully, you guys can be the leaders to show how we can make sure that primary care is utilized in that environment and also proper utilization of services.
So, somewhat like a comment as well as a question, I'll let Jay respond.
Well, in fact, managed care is doing really wonderfully in New York State. If you go on the website, we just released last week the 2008 Katherine Swartz scores, which measure all of the health plans and measure them for Medicaid, but measure them against commercial insurers in the state. So I encourage you all to take a look at that. New York is now among in the top 5 percentile nationwide in its Medicaid program. The gap between commercial and Medicaid programs is narrowing. In fact, in a number of key areas like diabetes management and prenatal care, we exceed commercial carriers. ER is a huge problem. ER is an enormous problem. There is, we have to be able to respect an individual's right to the sort of prudent layperson about when to go to the ER. We cannot restrict that access. And we have tried numerous mechanisms in the managed care program to really put some barriers on, and I think we've all stepped away from it because of risk, because of the challenges and the difficulties. But we are going to be doing an ER diversion program in the upcoming year. We think that with the implementation of medical home, with having every patient in Medicaid assigned a primary care provider, which is what managed care offers. We do take some steps, but we have a huge cultural problem. In fact, the vast majority of admissions, as you referenced, Catherine, and as you know, come through the ER. And we need hospital partners in order to make that change, because I think it's in the ER we're going to have to make some of the interventions.
I have a question for the group, and that is probably directed more towards Kathy, because you've been in Massachusetts and you're a little bit further ahead in this game than we are. And how has the state been able to keep the conversations going? In New York, we have the advantage or disadvantage, depending on what your viewpoint is, of having a large Medicaid program so that the state can be a policymaker, can be a policy leader through its Medicaid program. But how did Massachusetts engage the community, and how did it become a leader in making sure that these reforms are happening?
I mean, I think the thing that's true about Massachusetts, and I don't know enough about New York, because it seems to me that, so let me start again. In Massachusetts, there have been these ongoing conversations for over 2 decades. And I think that's an important point that, many of you know this. I don't think you can get this kind of reform without having a lot of people who feel like they've been through this, and in particular over the last, for about 3 years prior to the legislation being passed in April 2006, the Blue Cross Blue Shield of Massachusetts Foundation held a number of forums like this. They were held at the Kennedy Library, and so not at the Kennedy School, at the Kennedy Library, so that a lot of people came into the corral, so to speak, that a lot of people felt they were stakeholders. They had large employers, they had smaller employers, they had people who run the hospitals, and it took a particular mix of people. So Nancy Turnbull, for example, who at the time headed up the foundation, but then left it and came back as a colleague of mine at the School of Public Health, I think is viewed by everybody as a totally honest broker. And so when she goes on the radio and talks about this is how it would affect you in these call-in shows where people will talk about, well, what kind of premium would I face and that kind of thing, she's very believed. And I think that a whole slew of those things were needed. The fact that it's a much smaller, geographically smaller state, I think is important. It's much harder here in New York the distances between Niagara Falls and Eastern Long Island, I know well, but you all know well too. I think that what's happened is that everybody felt that they had a stake in this game, that they wanted it to work. And I think it was very lucky that Governor Romney was the governor, believe it or not, because he said we should require people to purchase health insurance. And I think a lot of that had to do with his own background as a Mormon, and the notion that there is a social compact, and that part of that social compact is that individuals are asked to do things themselves. And he broke the taboo of talking about a mandate. That was a huge step forward. Even though when he was a candidate for president, he repudiated the Massachusetts experience, it didn't matter at that point. The deed was done. We could talk about this. And so I think this continues today, that there is a strong will among the people who lead that state that this will work. The current governor is, I think, more caught by the funding problem. So whether or not he will do something about this, I don't know. It's not clear. So for New York, it's a very different situation. You guys know this better than I do.
I'm David Sandman from the New York State Health Foundation. So Kathy, continuing that, I think it was smarter Massachusetts to just kick the can about cost containment far down the road because you couldn't have gotten this on the books otherwise. But you and other speakers said, we can't expand unless we contain costs. So, and they set up a council, which is a good way to avoid dealing with problems too, for a while. When that bill comes due, what is Massachusetts seriously considering doing for cost containment?
It's a really good question. I think one of the problems is that, I completely agree with. The first step is come up with a plan that everybody can have health insurance because It's a lot easier to do something when everybody's inside that tent. And as long as there are people outside the tent, they become a safety valve, and I think there's less sense of what are we going to do. And so in some ways, this recession provides this opportunity to think of something to get everybody inside the tent, especially if there are a lot of middle-class people who've lost their access to health insurance because they've lost their jobs. So, that's a big thing, I think, to really take advantage of right now, especially at the federal level. The Cost Control Council in Massachusetts was definitely viewed as second step, and it sort of got put off in terms of the funding for it, and also who would go on it. There's an enormous knowledge of who's on the connector board. I don't think I can tell you anybody who's on the Cost Control Council. And I had thought that they would go to several people, possibly me, although I wasn't angling for it at all, don't misunderstand me. But I don't know who's on that council. And the staffing for it is, I started to say this and I realized I was really running out of time. The staffing on this is starkly different from the connector. The connector has money. The connector hired a lot of people. Has money to go out and get consultants. The council's staffing is all coming through the Medicaid office and the Division of Financial Security and whatever. And that's just a totally different. Everybody knows it doesn't have as much teeth, and the question is whether or not the governor is really going to try to give it more standing. And he has not been. How do I say? He has not been aggressive about figuring out how to get money that the state needs. He's much more like, I'll let everybody else do this and then say something. So we've passed the sales tax, for example, in the Senate this week. But the real fight's going to be in the House. And I don't know what's going to come there. But we have roads that are in terrible shape. He couldn't even lead on what to do about that. How should we fund that? So this question of what's he going to do about costs in Massachusetts related to medical care, I'm a little uneasy. He does not have the same stake in this game that others who have been political leaders do. And of course, we've lost DeMacy was the Speaker of the House, and he's no longer the Speaker of the House. So there's a lot of change now. And from other states like Oregon, where when Kitzhaber was the governor, everybody was really gung-ho to do this. Kitzhaber gets termed out. The next guy comes along and says, well, that's his issue. It's not mine. So, in a recession. Yeah.
Two questions. The first one is fairly technical. I'm Ray Sherman, I'm the CEO at Parsons Child and Family Center here in town. I wonder what potential you see for the stimulus-supported electronic medical record for controlling costs relative to procedures first. And then secondly, would your comments apply to mental health as well as they apply to physical health?
Okay, so let me take the easier one, which is electronic medical records. I think everybody who is involved with electronic medical records and the building of the platforms for that, the architecture for this, agrees that this is something that is going to take at least 5 years, probably a decade, before we see any kind of cost savings coming out of it. But there's no question that without that kind of infrastructure commitment, that it's going to be much tougher to get efficiencies and at the same time quality of care. So I think that having a commitment to creating standards of what that software construction architecture should look like, we have to do. It's clear that there are at least 10 companies that build this software, and Microsoft has not emerged from it. So the market's not going to create a leader, and I think everybody else is afraid to do anything without somebody saying, this is the standard. So having David Blumenthal head that office within the federal government for this, I think, is a good first step in that. I think that part of the issue is getting a handle on certain types of diagnostic testing. I mean, that's my particular thing, because I think it really shows up in radiological scanning. That's where we've seen huge growth in expenditures. And a lot of that, what's unnecessary is in the beholder, right? But fundamentally, we don't know all the variation in people's bodies. So every time you do a scan and you find something that's not what is, quote, normal, the standard procedure right now is that 6 months later or 3 months later, you come back for a second scan, and then again, 3 or 6 months later, a third scan, and then you look at differences in differences, to borrow an economist's methods typically. All you're doing is seeing, did anything change? And if it didn't changed, and they say go away for at least a year. But that costs a lot of money to do those 3 scans. And what we're building is knowledge about how different bodies are. And I think that the question is, are we going to just let that happen, or are we going to say we need to have more control over situations where we think it's probably not necessary to do that? And I think what you were talking about with what Medicaid's doing is a good example of that. And whether the electronic medical records help with that or not depends really on the architecture. So for example, I can tell you why my father had this happen. In spite of the fact that the surgeon knew that he had Parkinson's, and all the pre-op stuff said, well, these are the pills he's taking, and they told my mother and sister to bring in his pills because the hospital doesn't stock them, which is typical for anything that's neurological, by the way. It's not just Parkinson's. He still wrote this prescription for a very powerful antibiotic and assumed, he told us this, he assumed the pharmacy of the hospital would tell him if there was a contraindication. Well, that's sort of like Atul Gawande and some of the surgeons talking about a 16-point checklist. There ought to be a 17th now. Because you can't assume that the pharmacy is going to know this. So would an electronic medical record have caught that? I don't know. If the architecture were done correctly, yes. And it would sure save a lot if we did this with just prescriptions alone of what everybody's taking. Because it's when people land in an ER and they don't have with them the current doses or the names and their spouse, or they don't come in with anybody and somebody doesn't know. So I think the electronic medical records over a decade's period clearly get us to more efficient care. Mental health, I don't know the answer really. I mean, I think there's a lot there we don't know.
I was just going to ask a follow-up on the radiology piece. I mean, you were comparing it vis-a-vis HIT, health information technology, medical records, whether that's going to work. But what else have you seen? Because clearly in New York, it's a huge issue, and we're sort of grappling with a couple different ways to support plans and efforts to try and deal with that. What have you seen that's worked, hasn't worked? Any ideas that you have that you think states should be trying to push on a policy level?
Well, I really do believe that a lot of our costs are coming from older patients, or people that have these chronic conditions. And so whether you call them older or chronic conditions, I guess chronic conditions is a nicer way of doing this. So one of the problems is that I think a lot of physicians, I know this actually, not I think, I know that physicians in their general training in medical school have very little interactions with older people or people that have these chronic conditions. And in fact, I have a physician I'm working with right now this year who is in part of the Southern California Kaiser organization. And he told me that when he was in medical school, they dreaded the 1-month rotation dealing with older people because they would be sent to the nursing home. And they would, a nursing home. They would be do everything they could to avoid going out there. And I said, do you mean to tell me you never ever saw an active 85-year-old? You don't know what a normal 85-year-old looks like? He said, no, I don't. And he was clearly embarrassed. It's a 33-year-old physician. And I think that's very typical. And I don't know how many of you know this, but we have a number of these funded fellowships in geriatrics around the United States. Do you know what the percentage of occupancy of these fellowships, I don't know what the right word is, do you think it's close to 100%? Do you think it's about 50%? Somewhere around 60 or something like that. And most of the people in these are graduates of foreign medical schools. So you've got two problems. You've got lots of physicians who don't know how to deal with those of us who are rapidly aging. I mean, in a decade, we're going to be a lot more people over 65. In 2 decades, we're going to be over 22% of the population are over 65. And we've got a whole slew of physicians who don't know how to listen to older people or people with chronic conditions who may have to speak slowly or whatever. And so what they tend to do is to talk loudly and fast so that they can get out of the room because the payment mechanism is set up to, you've got 5 minutes. And it really takes longer. So that's where the Medicaid paying more and private insurers paying more, or Medicare also, paying more for people who have a chronic condition. Another thing is just write out the instructions. I think a lot of rehospitalizations are due to somebody not really understanding what the instructions are. And I guarantee you, if any of you go into a physician with your parent, ask the parent what they think they've heard, and you'll have heard something different. And it's just astonishing to me that these just simple things. And I think that there are a number of nurses, like the dean of the nursing school at NYU is very aware of this, really pushing that there should be more nurse practitioners. And I think that's right. Now, those are small things. They aren't diagnostic testing, but they are the beginning, or the emphasis should be on treat somebody in an office rather than in the emergency room. As soon as they're in the emergency room, all the diagnostic testing takes over. And that's where I think a lot of this money is. The truth is, it's only in this last 5 years or so that we're able to link these episodes of care at a detailed enough level that I think we can start figuring out why somebody's a high-cost person. But if part of the why is that they didn't see somebody in the physician's office, or the physician decided that they should go to the hospital to have the monitoring done rather than having a monitor that sends signals in every 2 hours to a nurse, I mean, to me that would save a lot more money. But we haven't built that kind of diagnostic equipment or capacity for it.
I think just to echo some of that is that, there are so many elements of this that the healthcare system needs reforming, and I think professional education is a very significant one. We highly train physicians to be diagnosticians, not necessarily to be educators or to change behavior. And behavior change, because chronic disease is largely related to health behaviors. And so changing health behaviors takes frequent interaction to make change. Any diabetic, training any diabetic to monitor their blood sugar or change their diet, any asthmatic to change their health triggers for asthma, or to do a peak flow, or to do any of the things they need, are things that we don't reimburse for. And last year, Medicaid took the first step to reimburse for asthma education. Well, one of the things that we did was we didn't want to make it Medicaid dependent. We wanted to bring other people into the marketplace and other insurers by doing that. So we picked an external standard, and there is a national body of asthma educators. Guess how many there are in New York? There's 93. And we also picked diabetes education. There's 190 of those. But it is one of the elements that we need to change the system, because we probably shouldn't be using a doctor to sit down for 30 minutes with someone and really educate them about diet. And I don't think the system can afford it, and I don't think that we best use their training. And so we have to begin, though, to pay for it. And the consequences are obvious when we don't. Asthma is the largest leading, ER admission, and it's oftentimes because parents don't know how to take care of their kids.
I think we're about out of time. The audience can join me in thanking our panel, and I also wanted to acknowledge the New York State Health Foundation, who has provided the grant that supported this forum today. So thank you for our panelists.